Thank you, Mr. Chairman. I want to go back to the cost question that you raised, but you were talking about the cost to the government, about Medicare Part D. I want to talk again about out-of-pocket costs to the individual consumer. And I'm back on this question about getting people to take their prescriptions. And if they don't have their prescriptions filled, and if they don't have them filled in a timely manner, so 30 days, every 30 days on a 30-day prescription, then obviously they can't get the benefits from those prescriptions. I understand there's a RAND study out now that shows that for every $10 increase in the copay on a prescription, that compliance rates on taking your medications dropped by about 5%. And we talked earlier about the importance of people taking those prescriptions if we're going to drive down costs and get good outcomes. Of course, this is, in my view, one of the best parts about the Affordable Care Act is to close the donut hole so that we get more people filling their prescriptions. And I understand the CBO says they believe that just closing the donut hole is going to increase drug compliance, people taking their prescriptions by about 5%, and that's going to save us about $35 billion. So these are very important about how we lower costs. And so I want to go back to this question about how we lower out-of-pocket costs for our consumers, how people can get those costs down. So, Mr. Romasco, go back to this question. What should we be doing?
Well, I think, I've touched on a couple of things that we think will have a significant impact on reining in these costs. Again, secretarial negotiating authority, the biologic window for closing that exclusivity on generics for biologic and biosimilars, I think are two possible avenues. A lot of the compliance issue, we talked about synchronization. If we look at the Affordable Care Act, the implementation of accountable care organizations begins to look at team approaches as opposed to silo approaches for the patient care. The coordination of care, which allows people to both get the support, not only of their physician, but of their team of medical professionals to focus on keeping the costs down and looking at the whole patient and all the dimensions of that.
Yeah, I appreciate that point because it really goes back to the point that Senator Nelson was making earlier. This is not just about the out-of-pocket costs of the drugs, and it's not just about what the government spends on the drugs initially. It's to the extent that it causes people not to have their prescriptions filled, that it increases costs on down the line. And so we're talking about a much larger impact of how the drugs are actually priced and the out-of-pocket part on that. Mr. Smith, I'll give you one more chance to say something about how we're going to bring those costs down.
Sure. So, I think that I've already made my points about some of the issues that Mr. Romasco made, and I'll just remind everyone, because he's referenced the biologics a few times, that in data exclusivity, that I actually think that the one provision of the Affordable Care Act that was passed with strong recorded bipartisan majorities in both chambers was the 12 years of data exclusivity as a balance between incenting the innovation that we all want to see and creating a biosimilar pathway for affordability. We are closing the coverage gap, and I would note that, let me take it outside of Part D for a moment, just as an example. I would note that there are a number of employers, for instance, who, looking at how to bring down their costs, have actually cut their copays for medicines. And they didn't do it just for generics. They did it for generics and they did it for brands because, as Senator Wyden pointed out, people are different, need different treatments. Some are going to need a brand medicine, others are going to be using a generic. They're finding that they're having good experience by actually reducing their copays, and it's helping them control costs. The final point I'll make is that the copay is not, medicines are about 10% of Medicare spending. Brand medicines, if you look at all federal Medicare and Medicaid spending, brand medicines are about 8% of all of that spending. So I don't think that I don't think that the kinds of proposals that have been suggested are what's really going to help improve adherence. I think it's some creativity, looking at how we tie medication therapy management to utilization, looking for opportunities to take advantage of the cost savings that medicines can bring.
Fair enough, Mr.
Yeah.
Smith, but surely you're not pushing back on the point. The RAND study, $10 increase in copay.
No.
Okay. I just want to make sure that you weren't saying. I may have misunderstood.
Okay.
So long as we're clear on that. And good. Dr. Hoadley, did you want to add anything on that?
Yeah, I think, you raise a really important point with the RAND study, and we've also done our own project, research project, and published an article on generic copays and how the use of a zero copay for generic drug can really increase utilization of that drug's adherence to that drug. And, as Mr. Smith said, some of the flexibility that's been tried in private plans with value-based insurance design lowering copays. The problem with doing that in Medicare is twofold. One is the basic design of Part D includes 25% average cost sharing. So a plan that wants to lower their copays overall either has to do it as an enhanced plan with a higher premium, and that is one approach. Or there's got to be some change in the legislation in terms of the overall average cost sharing level and bringing it down lower than 25%. And obviously there are implications for doing that. But even within that, perhaps, some greater flexibility that CMS could look at in terms of letting plans experiment with lower copays for certain classes of drugs that are really much more important clinically is something to think about. But also certainly trying to push plans, encourage plans to look at lower copays for generics where you can get more bang for the buck. The last comment I would make is one of the things that really complicates the story for the Part D program is that in the world of standalone drug plans, if we increase adherence, we're actually increasing the amount of spending that the plans are on the hook for. And so we've built in kind of a perverse incentive to say, they're going to do better when less spending occurs on the drugs, whereas in fact we may want more spending on drugs to get the higher recurrence, to get the payoff in Part A and Part B. And so figuring out a way to change and rethink about how we build the standalone drug plans to get away from that perverse incentive is something really worth trying to think about. That's
a very good point. And Dr. Woerner, did you want to add anything to this? I am over time, so I'll ask you to be brief.
Only that I think by simplifying the process of choosing a plan, it would help individuals find plans in which their costs would be lower. And that's a minor thing, but it's something that could be done.
I don't see it as minor.
Yes.
I take it to be a good point, but I do understand that if we're trying to reduce costs overall, copay costs for the individual must come down, and that we're just caught in the wrong cycle right now with high copays. And we've got to change that if we're going to have better outcomes at lower costs. Good. Thank you all.